Okay, so welcome to today's Power Hour. And Andy, just so you know, we, try and feel more informed and, powerful in a way. So that's why we came up with the term P10 Power Hour. And, I'm very excited and pleased to introduce Dr. Andy Latchford, who is a consultant gastroenterologist at St. Mark's Hospital, and he's also the director of the polyposis registry there. And, obviously, as a doctor, and he has sent me his bio, and it says in bullet points, he provides clinical care, endoscopic surveillance, and endoscopy therapy for patients with polyposis syndromes and other high risk groups. So I guess that's, you know, Andy as a gastroenterologist. But Andy has also is involved in a lot of many ongoing European and other international research collaborations in polyposis syndrome. And he's been involved at national and international level for numerous guidelines for polyposis syndromes. And he is also a collaborator in the mTOR pathway disease note. And that it's actually at one of these events where I met Andy for the first time. So it's an NHS rare disease research initiative, which will include a number of polyposis syndromes, including PTEN hamartoma tumor syndrome or PTEN. So again, thank you very much for joining us today, Andy.
Oh, my pleasure.
I'm just gonna spotlight you. Yes. So, as I mentioned earlier, Andy, we're going to keep it as a chat show format. Do not expect Jonathan Ross or Graham Norton level of chat show hosting from me. But I've come up with sort of a list of questions, and some of our patient community members have sent in questions as well. So I'll try and incorporate those. And if people have questions, please, you can raise your hand and or you can just unmute yourself and speak or put it in the chat, and we'll try and get through as many questions as possible. So, we're here today to talk all about polyps. So I will start with the most basic question, which is what are polyps? And I guess most of the people here probably know what polyps are, but if they are newly diagnosed patients or parents of newly diagnosed patients, if you could tell us what are polyps?
Yeah, well, polyps are growths within the bowel, and they can look very different, and there's lots of different types of them. But people often just refer to them as a fleshy lump. Sometimes they can look a bit like a cherry on a stalk. Sometimes they can be like a squashed raisin lying very flat to the lining of the bowel. There's lots of different names, all of which are quite confusing and all of which are long, and most of which make no sense whatsoever. But I guess the important thing that one needs to think about for polyps is one key thing is that some of them can predispose to bowel cancer, and if left untreated, can progress to a cancer, and others don't. They just sit there quite calmly doing nothing at all, but may just ooze a little bit of blood and cause people to be anemic. And with P10 in particular, there's really quite a huge variation, both in the number of these polyps, but also the type of polyp that is seen. So people often get very worried saying, oh, I've got lots of polyps in my bowel with P10. And to me, that's not the problem. I don't mind if you've got lots of polyps. What I want to know is what type of polyp they are. And are they the ones that we can just ignore and just leave alone? Or are they the ones that we need to treat to prevent bowel cancer? So fleshy lumps, lots of long names, which are very confusing. But the key thing is that some can turn to cancer if not treated, and others don't.
So when you say that, the ones that might cause cancer are the ones that you would, further investigate and stuff, how do you know which ones to look at? Is it during, the most common diagnosis method? And, I was going to come to diagnosis a bit later, but it's endoscopy. So do you just look at it and just looking at the morphology, the structure of it, does it tell you that this is, not something one should worry about, or this is one that
Yeah.
one should worry about?
Well, the ones that we do need to worry about are usually the ones that we see commonly in the general population. So people's eyes are attuned to looking at that. And it's a bit like pattern recognition in the same way is that, you can see something with four legs and a tail and a furry coat walking down the street, and you know it's a dog because of pattern recognition. And even though there's lots of different types of dogs, you know it's still a dog, because you're just used to seeing it, and you know that's what a dog looks like. So with people who do a lot of colonoscopy, we're able just to look at the polyps. And for the ones that are the most common, and the ones which are important in PTEN, are the ones that can progress to cancer, we're quite used to looking at those all of the time and looking to treat them. So we kind of very much have in our mind's eye like a pattern recognition. Doctors call it, if you sometimes see in reports, optical diagnosis. That basically means they've had a look and this is what they think it is. And there's quite good correlation between that for people who are used to looking, to looking at colonoscopies on a regular basis. So yeah, actually, it's as you say, it's looking at it with the camera and it's pattern recognition, and we're right in the vast majority of the times.
Okay. And as you said that patients can have hundreds of polyps, and I
Mm.
think PHTS patients do tend to have, a few hundred polyps sometimes. What is the frequency of these? How many of these, say, out of every 100 polyps, how many do you think are the ones that one should be concerned about, or the one that can lead to cancer?
Really good question. So the honest answer, and I'm usually quite honest, is we don't really know.
Okay.
Okay, that's the honest answer. So, a lot of the things which we read about or which we'll talk about in terms of guidelines and the so-called facts that are known about PTEN, I think we have to take them with a pinch of salt. What I would say is that there's a huge variation. I've got some patients with PTEN who almost have no polyps, and
Yeah.
I've had some patients with PTEN who've had hundreds and thousands of polyps.
Yeah.
I think within the patient group with PTEN, there's a huge spectrum in both the number of polyps, the types of polyps, and I think actually what we don't know is how often within PTEN we find the ones which are the risk ones, and people call them adenomas or serrated polyps or juvenile type hematomas. Those are the three ones that people get worried about. I don't think we really know is the honest answer, because I think most of the time we haven't got those data where we've got very good quality colonoscopy over a number of years in a big group of people to really inform us.
Yeah. And sorry, I'm just bring up my questions. So you said that you can have hundreds and thousands of polyps, and then you
Mm.
have 10 patients who do not have polyps, and we've got the adenomas and the ones that are benign. So what is it that you would normally do during an endoscopy to confirm that it is something that one shouldn't worry about? So
So the first thing, I mean, I always talk about colonoscopy. The first thing about colonoscopy is informing the patients about what it's about, educating them in terms of the bowel prep. Actually, they become the masters of bowel prep. They know exactly what they're doing after a while and learn the tips and tricks to make it easier. But having a really well prepared bowel is the most important thing. And then the endoscopist, being someone who's used to looking at PTEN, not being phased by the fact that there may be a lot of things there, and really taking their time to look carefully and methodically. Because for me, there's no better substitute than a very careful look. Now, that does
mm,
mean that the procedures are a bit longer than otherwise one would, for some patients, particularly if they've got more of the polyps.
mm,
And at that time, if we see polyps that we're worried about, as in polyps that we think are the precancerous type, then we will go ahead and remove them. And that's painless. You shouldn't feel that at all. For the ones which we can look at and say, well, those aren't the type that we're worried about, most of the time we don't do anything. We just ignore them completely. Sometimes if it's something that's very big and or it looks like it's oozing blood and patients have problems with a low blood count or anemia, then sometimes we remove them just because it may help the symptom, but not because we worry that it's a precancerous polyp.
okay. And maybe I've got this wrong, and that maybe this is just my
Mm.
lack of medical knowledge, but we've used the term bowel, endoscopist, and colonoscopy. So
Okay, yeah,
do PTEN patients just have polyps in, when you say bowel, I think the large
yeah.
bowel. Is that correct?
Yeah, so I'm talking, yeah, just in common term, bowel, but there's the large bowel, which is what people normally think of as like their colon or bowel cancer, and that's the area that we look at with a colonoscopy.
Okay.
So, so people often use the terms colon, rectum, large
Yeah.
bowel are the same sort of thing. Some people talk about an endoscopic examination of the large bowel. That's a colonoscopy. So we use colonoscopy sometimes interchangeably. And the person that does the procedure, well, you can call them an endoscopist because it's an endoscopy procedure, or you can call them a colonoscopist when they're doing the procedure specifically for the bowel. So you're right. Sometimes we use the terms interchangeably, and it's a bit confusing.
Okay. So am I correct in getting that the polyps are usually just in the colon or the large bowel? Because I've seen patients mention that they have polyps throughout their GI
Mm,
tract, in
yeah.
the stomach as well. Is that something that happens?
Yes, it is. So we know that in the large bowel or the colon that you'll probably find polyps in 80 to 90% of patients with PTEN,
Okay. Yeah.
roughly.
Yeah.
In terms of this stuff, and the reason why that's important is that there's about cancer prevention. And if we just deal with that now, because I guess people will want to know, because that's what this is all about. We don't really know the risk of cancer for bowel cancer or large bowel cancer for patients with PTEN. It probably is greater than the general population, but how much greater is really unclear. So the sort of ballpark figure that people will quote, a lifetime risk, is probably in the order of about 10%. And
Yeah.
in the general population, it's probably about 5 to 6%.
Yeah, that's really interesting because I always used to think that it's about that 10% mark based on what, Karaseng has published.
Mm,
But Nicolene Hugebrugge, she published, I think last year, and her paper just says there's no colon cancer risk, at least in the European cohort of patients she looked at. So I think it
it's
definitely
it's
varies
really
from study to
difficult. It's
study.
really difficult because I kind of usually use that figure because A, it's easy to remember, and
Yeah,
B, it sort of sits halfway in the spectrum of risks that are quoted. Because there are some papers that have quoted it up to 15%, 16%.
yeah,
Some people don't. So it's really not well known. So for the large bowel, we polyps common, bowel cancer actually not very common in terms of lifetime risk. And then that's the reason why that we've said that bit now is you're right that you can get polyps in the stomach. How often? Not entirely sure. Do we have an increased risk of stomach cancer? Actually, probably not significantly raised. And that's why most people don't advocate, or at least in the UK and in Europe, don't advocate routine endoscopies to look down the gullet inside the stomach. They used to,
yeah.
but and people will probably, some of your older patients will probably remember those procedures, probably not too fondly. But the guideline really says not to do it. And because we don't know that there's an increased risk, in actual fact, and we don't know that those procedures give the patients any benefit whatsoever.
Okay. So while we are talking, about diagnosis and surveillance
Mm.
in a way, the recommended age for surveillance for the bowel in PHTS is from the age of 37 to 40. So, once you're over 35 or 37, I think I checked. Let me just check my notes.
Yeah, 35 to 40
Yes,
is
30,
what we, yeah.
35 to 40 years, and it's a baseline colonoscopy. But we've
Mm.
had many, many patients who have been diagnosed with polyps as, in their late teens or when they're young adults.
Yeah.
So, because you said that you can have polyps without it affecting you, you do not have, any severe symptoms.
Mm.
And, again, maybe if you could repeat what sort of symptoms people should, because that was one of the questions I had. What
Mm.
should one look out for? Because I think in these patients, it's gotten quite bad and they've had discomfort, gone for a checkup, and then, the doctors asked them for a colonoscopy, and then they found that they've got hundreds of polyps and they're about, in their late teens or
Yeah.
early 20s. So do you think that the surveillance guidelines need to change, or what would your advice be for patients? Like, what are the things they should look out for? Because it's very difficult to say, which patients would have them earlier, like the whole, how do you predict the phenotype? Is there genotype phenotype correlation? As researchers, we can keep talking about that, but I think for the
Yeah,
patient community, if you could
sure.
give any advice on.
So I think the advice is exactly the same as I would give to anybody with a genetic problem that puts them at a high risk of developing cancer, in that we have a guideline of when to start, but that guideline is for patients who don't have symptoms. Okay, so there are many ways to get into this diagnosis. But if you don't have symptoms, then it's usually safe to leave to that age on the basis that bowel cancer doesn't occur at a young age, specifically in PTEN. Actually, it's not very different from the general population, the ages at which we see it. That said, if you have symptoms, then one should always be mindful of that, and people should always be mindful that there is this genetic condition, and that one does need to take that into account, and you should be considered for earlier investigations if you have symptoms. And the main symptoms will be bleeding from the bottom. That is one of the key things, which will probably be a very common presentation for your younger patient group. Other ones which we talk about are persistent change in bowel habit. Well, that's not usually related to polyps. That's more of a worrying symptom for cancer, but again, a symptom that your patient group should be very mindful of. And the other thing which will probably occur is people who are found to be anemic, and that's often a common routine. Even if they've not noticed overt bleeding, they may be found to be anemic on a blood test, and that then triggers for investigations. Of course, being anemic in ladies who are menstruating is quite common. So ladies with periods being a bit anemic is not uncommon. So it's sort of like put into the context of that individual's past history. For men to be anemic is an unusual thing. And so again, there's a slight differences in how that gets interpreted between men and women. But bleeding, a low blood count, are probably the two most common routes in for a younger patient. And then one has to be a little bit pragmatic. So you're right. Some of them will have a colonoscopy in their 20s, found lots to have lots and lots of polyps. It would seem wrong to then say, "Oh, actually, we're now going to do nothing till you're 35 to 40." So I think when somebody's diagnosed with that, we then try and tailor what we do for an individual. So it all becomes personalized rather than a generic, this is how often it's done and this is when it's done. And so for me, it would depend on how happy I am with the quality of the colonoscopy, how happy am I about what was seen and the types of polyps that were seen. If there were any of the worrying polyps which we looked to remove, I would absolutely bring patients back for further investigations, although how often would depend on how many and the size of those polyps. So there's not a kind of a hard and fixed rule here. I think if you present earlier, yes, you're likely to get some ongoing monitoring, but it will depend very much on the number and the size and the type of polyp.
Okay. It's interesting you say that if you are diagnosed in your 20s, then they will sort of do routine screening, because to prepare for today's talk with you, I actually went through PTEN UKI Facebook page, and I was just looking at people who've spoken about their experience with polyps and if there were any questions. And I think one patient did put that, this was a parent, and she put that her daughter was diagnosed with polyps when she was 20, and they
Mm.
did the endoscopy or colonoscopy. And then they said, right now you don't need to, and she had hundreds of polyps, but then she was told, right, you don't need to do anything. Come back when you're 37. So that's
It can be really difficult because this is, people will probably have some slight differences of opinion, and people will be more favor monitoring and some people favor less. I think historically probably too much was done for both colonoscopy and the top end upper GI endoscopy. And I think, we have to kind of get some sort of pragmatic middle ground. For
yeah,
me, it will depend. If somebody had some bleeding and they had a colonoscopy and there was a solitary but bigger, completely benign polyp that was removed and the rest of the bowel was clear at the age of 20, would I offer them very regular colonoscopy? No, probably not. That patient probably could wait till they're 35.
okay.
If they had any of the kind of the more worrying polyps, what we call adenomas or serrated polyps or juvenile type polyps, would I leave them for 15 years? No, I probably wouldn't. But how
Okay.
often I would do it, I don't know. And that's where it's a kind of a conversation between the patient and the person who's doing the procedures. But I think having somebody who is used to looking at PTEN is really helpful. And of course, that's difficult with rare diseases. So one of the other things I think is really important is that when you have your diagnosis, is that you kind of ask the geneticist, because that's the most common routine, to say, okay, well, who is your local specialist that is used to scoping patients with PTEN, please, and can I please be referred there? And I think that's really empowering the patients to do that.
Yeah, I think that's a really good piece of advice. We've got a question about, we're talking about the age at which patients can
Mm.
get polyps. There's a question from Ryan and Bernice here, and they've asked, what is the youngest a P10 patient can get polyps?
Well, I can't give you the absolute youngest, but it probably can occur at any age. Certainly, I've seen patients present to our paediatric colleagues, under the age of 10. But remember that with P10, it is we talking here about the about polyps in the bowel, but actually, in the global scheme of things, it's not really the major issue in P10 disease, but it can contribute to diagnosis, particularly in the younger patient group. And so this is why some of it's very difficult, because those children will present at an earlier age, and therefore those people who've got more polyps and more worrying things may be diagnosed at an early age and cause anxiety, whereas there may be some people who are never been diagnosed with PTEN because they've never developed significant polyps, and they were one of the few that didn't have any of the other kind of aspects of it, maybe apart from the macrocephaly, the big head, and so they may have never made a diagnosis, and so those ones are invisible to us. But you do get patients in childhood, and that's why I think it's really just important to be just aware of the symptoms. Bleeding from the bottom is always something that should be taken seriously, and that will be the most common presentation in childhood.
Okay. We have a
And
comment here
we
from, yeah,
diagnosed at the age of 8.
8, yeah.
Exactly. Yeah.
So,
And a really interesting comment above that I've just seen that's
yeah, I was going to come to that
yeah,
about the actual colonoscopy, and I've got a
yeah,
question from another patient, but we'll
sure.
take the question over here. It just says it's from Samsung SM
Yeah.
something. So I'm not sure who has asked the question, but it is about asking for pain relief during a
Mm.
endoscopy or colonoscopy, other than just sedation. Is that routine? And if a patient was to ask for that, would you be given that?
Yeah. So this is all about, again, so let me empower your patients. Please talk to the people who are going to be doing your procedure. So there are some things. So essentially, what most people who do these procedures would say the vast majority, it shouldn't be painful. And for many, taking the medicine to clear out the bowel and being starved for 24 hours is worse than the procedure.
Yeah.
That said, everybody experiences things differently. And for some people who've had, for example, operations, it may become technically more difficult and be a bit more painful. So talk to the person doing your procedure up front. Talk to them about your previous experiences. If you've had painful experiences, say to them, I've had a painful experience before. Please look at what I had last time. It wasn't enough. And then talk to them, because yes, I use gas and air. I offer it routinely in addition to the drugs that we administered into the veins, the intravenous sedation. And so my talk, and if there's any patients on here related to me or anybody who works with me, I always talk about it in terms of alcohol, because many people will kind of have drunk some alcohol and have a feeling. And my usual pitch is, depending on what they drink, is that we have about a bottle of gin, a couple of bottles of wine, or about 10 pints of beer. Okay. And I can give you that. But what I normally would say is that for the vast majority, actually, a couple of double gins, a couple of big glasses of wine, or a couple of pints of beer actually is all that they will need. But if they want to have the laughing gas on top, they can absolutely do so. And if that's still not enough, I will give them a bit more gin, beer, wine, with my special wine that goes into the veins and doesn't give a hangover. So we've got all these options open to us. Now, with that, I would say, 95, 96, 97% of my patients will go through it without any problem. But occasionally, particularly for people who've had previous surgery, occasionally we have people who find that even with that, it's just too uncomfortable. In which case, talk to your people that are looking after you, tell them, because then many hospitals will have the facility to be able to give patients a form of an anaesthetic for the procedure. We don't usually give it to all our patients because most of the time it's just not required. And we don't have anaesthetic lists all the time. But it's certainly something that could be considered for people who have a lot of pain. And the other thing to say, some people are the opposite. Some people sail through it, hardly blinking. And for them, they need to be empowered to say, do you know what? Can I not have sedation? Can I just have a couple of puffs of the laughing gas, please? Because I don't find that I need it. And that way they're kind of free then to be able to drive themselves back home, go and have a drink of alcohol later at night, go into town and do the shopping all on their own. All the bits and bobs that go along with having a sedation are removed. So as with everything that is to do with PTEN and polyposis, it should be personalised. So you should be able to talk to the people doing the procedures, explain your past experiences, and everything should be adapted to do that.
Okay. So continuing on the topic of the actual procedure of endoscopy,
Mm.
we've got a question here from Kelly, which is, have you ever had any experience of doing these procedures on P10 patients with learning difficulties or autism?
Yes, yes, and indeed, not just with PTEN, but all conditions. And it is very doable. But what is really, really important is that there's an upfront and frank discussion in the clinic before you ever get anywhere near the endoscopy department. So what the doctors and the nursing team won't know is about an individual's very specific needs, because learning difficulties in autism is clearly a huge spectrum. What we need to do is come to an agreement between the medical staff, the patients and the patient's family and carers about what's appropriate for that individual. Now, I've certainly had some people with really quite significant learning difficulties and autism who have sailed through colonoscopy with just my standard gin and tonic. But
We
I've
all
also had other patients for whom it was clear that that was never going to be the appropriate approach, and we went straight for an anaesthetic.
okay.
So this is all about that conversation and a real importance of understanding up front, and therefore we can devise what will be appropriate for that individual and plan accordingly. Because some of them, it's not just the procedure; it may be that they need to have, considerations about what would be a better prep for them in terms of, like, they have to drink the stuff to clear out the bowel. If they're not able to drink lots, well, maybe have to consider changing the prep to smaller volume bowel prep. It may be that they need special admission areas, so they're not in a big busy waiting area. They've got a quiet room where a parent or a carer can stay with them. For my cases, I'm very happy for parents and carers to come into the procedure room. It just needs a bit of discussion before and a bit of ground rules. But I'm very happy for that, because actually, why wouldn't I? Because actually having the right person there is probably just as helpful as having the sedation. So I'm very open to that. And again, this is a conversation, and don't be shy about saying and advocating for the patient that can't, to say, I worry, these are the restrictions, this is our experience, this is what their special needs are. Really help the person make the right decision when it comes to the procedures.
So is colonoscopy the only method? Because I had another patient, reach out with a question that she had done, I guess, the bowel prep. As you said, you have to
Mm.
drink probably what's like a laxative to clear out your bowel. And
It's
it
not
made her
nice.
really unwell. And I've had endoscopy and colonoscopies, and when I was young, so I know it's not pleasant. But yeah, and she said her blood pressure got really low, she got really unwell, and she couldn't have the procedure. And
Yep.
she has asked this question, and sort of, Kelly has asked a similar question. Is there an alternative? Is there procedure, different procedure, if that might be more comfortable or less sort of, doesn't need bowel prep. Uh,
So the
and
honest answer is probably not. Okay,
okay,
so if we look, there are options that people hear about. So there's so let's just go through them. So some people hear about what we hear in terms of national bowel cancer screening, where they test poo for blood. So basically, you poo in a pot and you dip it to see whether there's blood there. That's only a screening test to bring out those that need to go off and have a colonoscopy. For most patients with PTEN, the fact that they've got polyps, it may well be that actually it's just going to be positive in any case. And what it doesn't tell us is the type of polyp that a patient with PTEN has. And that, as I said earlier on, is the key thing. So I don't think the stool testing thing is really the right thing for the vast majority. For that said, when you get bowel cancer screening age, national bowel cancer screening age, and they offer it to you, then it does you no harm in doing it. But just be mindful that actually interpreting the results can be very difficult. So the other thing that people hear about is, can they have a CT scan, like a special X-ray examination of the bowel? And what they do with that, they still give you something to drink, which is pretty unpleasant and has a laxative effect. They pop a balloon up your bottom, they inflate the balloon to create a seal, and then puff your bowel full of air. And then they, with the combination of the drink, bowel full of air, distending it really means that they can pick up polyps very well with that procedure. It's sort of, as you can imagine, having your bowel pumped full of air, it's a bit uncomfortable because you feel like you're really being blown up with gas. But perhaps no more uncomfortable than some colonoscopy. But the problem again is that the CT scan for many patients with PTEN will just say, oh, they're polyps.
yeah,
And again, it doesn't tell you the type of polyp that's there. And as I said, it's the type of polyp and the identification of the right polyps to remove that's key here. So I don't really think either of those are good options. And then the final option that some people hear about is a colon capsule, which is a little capsule that you swallow and takes like a video as it goes through the bowel, and then you can watch it on TV. Again, if you're going to do that well, you're going to need to have some sort of bowel prep. So that bit's still there. And my worry is that you can't control the capsule.
It's beautiful.
sorry, we've got
That's all
somebody's
right, no problems.
just
The
gonna.
problem with that is that you can't control the capsule to make it go back and look at an area where you thought you may have seen a specific type of polyp, and it doesn't remove polyps. So for all of those reasons, I'm not really convinced that there is a good alternative. But what I would say is that some people do react badly to some types of bowel prep, but there are lots of different bowel preps that can be used. And so sometimes you find you get on very badly with one, but another one can be used which you prefer because it has a better effect on your bowel. It may taste a little bit nicer. It may be a different volume that you can tolerate better. So again, it's a conversation to be had with the people who are likely to be doing your procedures. If you found something that was ghastly before, tell them. If it was just ghastly because it gave you terrible diarrhea and it didn't taste very nice, well, I'm afraid all of them, being honest, are going to have that effect. But there are things that you can do for the taste, but the diarrhea bit, I'm afraid that's what they're designed to do.
Yeah. There's another question from Kelly. So I think Kelly's son Austin. He has autism. I don't know, Kelly. Do you want to come? Do you want to ask this question in person? Give a little bit of background.
Hello.
You're still there.
Sorry.
Hi
Hi
there.
there.
Hi, thank you. By the way, it's been really interesting, and thank you, Prank, for hosting it tonight. So yeah, it's been fantastic. So which one? My question about about if you have to have the anaesthetic.
Yes.
So yeah, everything you're saying about the children with the learning difficulties and things. So my son's 13. He's mentally probably about 4, 5. He's non-verbal.
Yeah.
So he's severely mentally disabled. So obviously this is like way in the future. He doesn't have any symptoms or anything at the moment, so it's nothing that I'm concerned about.
Yeah.
But let's say he gets the age of 35 and then he's he starts screening. If he's going to have anaesthetic, is it still then advised that it's done every year? Because that's going to be quite a big thing to do, isn't it? Or would you even say don't worry because the risks are only 10%? Don't know, what would you think?
Yeah, so I'd say, number one, we wouldn't be recommending necessarily yearly colonoscopy. So you do a baseline then, and then work out from there what we would need thereafter. So this is providing he has no symptoms till he's 35. What I would say is that by the time he's approaching that age, you will get probably a much better feel for just how he interacts with medical people.
Mhm.
And I would say that for the vast majority, meeting them up front, probably ideally the person who's going to be doing the procedure. So the patients that I see, I will see them all in clinic with the family, with the carers, and I will list them for me specifically to do. So there's a familiar face. And if I've seen them 2 or 3 times beforehand, and that makes things easier, we'll see them 2 or 3 times beforehand. And then I ask, and I would say to you, okay, Kelly, what's the best thing here? How's he going to behave with me? If I wanted to pop a little needle in his arm to give him a sedative, is he okay with that? Is that going to become a problem? If we're going to need to pop a tube up his bottom and have a look around, is he going to be okay if you're there? And you're there and he's reassured by that, or is that going to be very traumatic? And we just have those discussions, and from there we work out what the right thing to do is, because I've seen from some patients who at first, when you see things written down, oh, they've got whatever, you would say, oh gosh, this is going to be really difficult colonoscopy. But actually, some of them who have had non-verbal behavioral difficulties with a family member in there actually sail through a colonoscopy and then offer me a Malteser afterwards. So, there isn't a fixed answer here, I guess, is what I'm saying. So when you're nearer the time, or if he has symptoms, just get the person who's going to be engage with the people doing the procedures, talk about what his individual needs are, understand by then how he interacts with the genetics, the genetic counselors, or the other people who are doing other aspects of the screening for PTEN, and then you are then in a position to help guide them about what the right thing to do for him is. But usually it's just having that conversation, and people who are used to looking after PTEN, I mean, I'm very happy just to have this conversation. We talk it through and be guided, because let's frankly, I wouldn't be the expert for your son, you are. Okay. And so I would be ridiculously stupid if I didn't listen to what you said.
Thank you very much. That's really good, helpful. Thank you.
No
I think along the lines of, have a conversation with your medical professionals. Jim has made a comment that, with the capsule, it might help if you can report that you've had ops on your bowel before they send it down. And he's got another one. Each time I have the catheter, I always give them a note explaining my worries and concerns. So exactly along the lines of what you've been saying, that, talk to the professionals who are going to do your colonoscopy, and, ask them to do what is required for you to make you comfortable.
I think
Okay.
that's right. Yeah.
Okay, so now the next sort of topic I'm going to, want to discuss is prevention. So we've had a few comments. There's the comment on, you are at the risk of polyps and a small, even if you say 10% risk of bowel cancer. Are there any lifestyle factors or, diet supplements that you can take to minimize the risk? And this is a comment here from Suzanne, and I had one sent in as well, which is, do you think it's advisable to have your colon removed as a prophylactic method to reduce your risk of cancer?
Yeah, that's on here as well. So really, really good questions. So what would I advise? I actually give the same advice that I would give anybody. Okay, so with PTEN, you have a genetic condition which is a proportion of your lifetime risk of developing bowel cancer. But also you have the same other aspects that would increase risk as the general population, which are related to all the lifestyle things that you read about. So being a non-smoker is good. Not having too much red meat is going to be good. Having a balanced, healthy diet is going to be good. Being fit and active and not overweight is going to be good. All those sorts of things. you know, it's a bit boring, isn't it? Because you kind of think, oh gosh, all the wonderful things in life are being taken away from me. Now, when I say all this, I always caveat it mean to say also, it doesn't mean to say no alcohol. Absolutely have a glass of champagne or gin and tonic or a glass of wine once in a while. That's absolutely fine, just not too much. Can you have a steak? Yes, absolutely, thoroughly condone it, but just not too much. So it's all about getting the right proportions. If you live off steak, sausage, and bacon like every day, then that is going to increase your risks over a number of years. So that's the diet thing. It's the same as the general population, a healthy, balanced diet without too many of the naughty things, but you still add a little bit of naughtiness. Lots of the good things, fruit, veg, brightly colored foods, naturally brightly colored foods, you know, high fiber, all those sorts of things are going to be the basics that you need for a diet. In terms of the other parts, so do we routinely recommend bowel surgery to prevent cancer? No. And the reason for that is twofold. But the main one is that it's just not required. For the vast majority, with good colonoscopy, actually, you're being kept safe from bowel cancer. And then if you were in a milder patient group where you might just need one at 35 or 40 and then maybe need nothing more till you're 50, 55, and, you know, or they're maybe 5 yearly, it's actually not very onerous in terms of the numbers of colonoscopies that you're having. And so for the vast majority, their risk of bowel cancer is nowhere near the level that we would be saying, do you know what, we would advocate for you to have routine bowel surgery. That said, there are some patients who have such extreme polyp burdens that the reality is that we can't safely monitor their bowel to look for the precancerous polyps because it's so difficult to see them. And have I had patients where we have had preventative bowel surgery in that setting? Yes, but not very, very many at all. So again, it's not a routine, but it's something that's very individualized. If you were somebody who an expert would say, I can't safely monitor this bowel to prevent bowel cancer, then there's a discussion to be had. But otherwise, as a routine, no.
So talking about polyp burden, like, let's talk about juvenile polyposis, because that is a common diagnosis which PTEN patients get. But I get my understanding is you have to have the mutation in PTEN and another gene which is located close to PTEN, and that's the reason why you get a lot of these polyps. Because I think because when everybody talks, they say, oh yeah, my child has juvenile polyposis. If there is a child with juvenile polyposis, if you could explain why is it different and what would be the guidelines. Is it the same as the PTEN guidelines or is it different? And we have a question here from, I'm guessing, the mother of 16-year-old patient. She says her son had juvenile polyposis when he was 10, and it was diagnosed because of a rectal prolapse, and then they found that it's polyps, and she is worried that I'm guessing that your child is not being screened regularly, and I think she's just worried, how can I be sure that there are no other issues, and her son has already had thyroid cancer.
Okay, so there's two parts to that. So the first thing is there's a juvenile polyp, which is just a type of polyp. It's nothing to do with age. It's a juvenile type hamartoma, which are one of the polyps that we see in patients with PTEN. And juvenile polyps are a potentially precancerous polyp. Okay. Juvenile polyposis is different. So juvenile polyposis just means lots of polyps. Juvenile polyposis is a very different disease or condition to PTEN. There are different genes that cause it. It has completely different risks associated with the disease. Now, what you refer to is a really small group, potentially, where you can have PTEN and juvenile polyposis. And that's a really small group. Even within PTEN and even within juvenile polyposis, which is also rare, they're a tiny, tiny minority. And that group is where you lose a whole bit of a chromosome. And that bit of the chromosome contains both a gene that causes juvenile polyposis and a gene that causes the PTEN gene. And so you can actually have manifestations of both conditions. And that is one of the ones which classically presents at a very young age with very severe and very many polyps throughout the gut. So for the 16-year-old having a solitary juvenile polyp, that's not uncommon. If the rest of the bowel is okay, then I'd be relatively relaxed. Is it the rectal prolapse? Yes, I can see how that could be a very easy misdiagnosis. And sometimes actually patients will describe something coming down and going back up, which can happen with a prolapse of the rectum, which is basically where the rectum comes out of the bum and then goes back up in again. But also a polyp can do exactly the same thing. It can flop down as somebody goes to the toilet and then flop back up again. So that's an important thing. So juvenile polyposis, juvenile polyps, and juvenile polyposis and PTEN are all three distinct things as a whole. Does that make sense?
Yeah.
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 And then in terms of the questions about this one, how can we show there are not other issues? Well, I'm guessing they would have probably had a full colonoscopy to look for other issues. And again, that would be something that I would be mindful of. And diarrhea, well, diarrhea is really difficult to tell. And there are very many causes for diarrhea. But certainly if somebody's had their thyroid removed and on thyroxine, then actually, yes, if you're getting higher doses of thyroxine, that can induce to go to the toilet more often. So it's difficult to unpick, but there's also lots of other causes of diarrhea, which aren't PTEN specific, that we see in the general population too. And so if diarrhea is an ongoing issue, I would definitely get that checked out. So your GP can do some of the basic tests or could refer you on to a pediatric gastroenterologist to look into that more.
Okay, thank you. Kelly's asked a question. Are we allowed to request a particular doctor for different procedures, or do you have to be have the doctor in your local area or hospital?
So a number of my patients ask for me only to do their procedures, and I go, that's fine.
Well, you're offering them gin and tonic and wine, so I'm not surprised.
I know. My patients love my booze. So what I would say to you, I think the most important thing is that somebody who can offer comfortable procedures and who knows what they're doing. And you're right that sometimes you find somebody that you get that trust with, and I think it's completely reasonable to say, thank you very much. Can I have you again, please, for the next procedure? And I haven't worked in the unit yet where people said no. Everywhere I've worked at, they say that's fine.
Okay. Celiac disease is something that we've had, members of the community ask about before, and Jim's asked that as well. I'm not sure what he means by Becky diagnosis.
So I guess it's important for somebody, for example, who's got diarrhea. But it's a really common condition. So probably, maybe 1 in 100 may have celiac disease. So, it's a relatively common thing. So there will undoubtedly be people with PTEN who also have celiac disease. So I don't think the two are linked. But what I would say is that if you've got symptoms, those always get investigated. That's the same for anemia. That's the same for diarrhea, etc. Celiac disease is very easily checked out with a blood test.
Okay, but you wouldn't say
that.
Yeah, you wouldn't say that if you have polyps, you might develop celiac disease. There isn't a direct correlation.
No, they're completely different things.
Okay. Another question from Wendy, which says, my mum had diverticulous and died of bowel cancer. My geneticist believes I inherited PTEN from her. I've just been diagnosed with diverticular disease. I wondered if there was something you've come across in any PTEN patients, or is it just something that happens?
It's just something that happens. So diverticulosis or diverticular disease, you hear it called all sorts of things, is really common in the Western world. There are some places where it isn't. So again, it's a very common thing, and more common as one gets older. So I think, again, it's just the combination of something that's very common, and therefore you're likely to see it in patients with PTEN just as you would in patients without. Does it change things? No. It just may mean that some people who've got significant or quite a lot of diverticular disease, it can sometimes make the colonoscopy a little bit more uncomfortable. But for the vast majority of people with diverticular disease, it doesn't really change the procedure at all, and doesn't change how often you would need to have the procedure done.
Okay. So we've got around 5 minutes left, and yeah, there aren't any questions. So I think, yeah,
There's one
there's
question which I didn't answer, Priyanka, which is part of the prevention and drugs. So shall I
yeah,
just mention that?
yeah.
So,
So,
for the general population, there are some data to say that if you take an aspirin, after about 10 years of taking aspirin, you may reduce your risk of developing a bowel cancer. There are no data for the aspirin really in patients with PTEN. Is there a specific drug that you can take to prevent bowel cancer if you've got PTEN? The current answer is nothing that we're routinely using. Now, there are drugs that are being thought about more generally, not just for PTEN, but for a group of conditions, all of which share, if you like, a common, what we call a pathway within the body. So this is where basically how the cells communicate with each other and regulation of how the body works. And there are a number of rare conditions all linked in with this, which we talked about earlier on, this mTOR pathway, and PTEN is part of that, as in actual fact is juvenile polyposis and some other polyposis syndromes. And there are drugs that we know that act specifically on that pathway, which are involved, therefore, for PTEN and these other conditions. None of them have really undergone the right sort of studies yet to say whether or not they will prevent bowel cancer. And so those studies will be difficult because it's such a rare condition and the risk of bowel cancer isn't particularly high. I guess one of the questions may be that if somebody's developing lots of polyps within their bowel and it's becoming more difficult to manage their bowel, is there a role for drugs then? Well, there's some very early data about using some drugs there, and with that, they're kind of not very clear on how, but certainly they said there may be a reduction in the number of polyps if you take some of these drugs. None of these drugs are right yet for routine clinical practice. None of them have undergone the right sort of studies that we would need to be recommending them. But what I'm just wanting to say is at the minute, on the horizon, there may be new things that will come along that may be used, which may have an effect not just for the bowel, but for other aspects of PTEN too. So it's quite unusual and quite novel and quite nice when you have a rare condition to say, actually, there may be something on the horizon, which is actively being looked at the moment. So at the minute, I would say for bowel prevention, bowel cancer prevention, colonoscopy is your friend, okay? Actually, good quality colonoscopy, I would be saying, is the most important thing. But in the future, who knows, there may be some drugs that are recommended.
yeah, I mean, there are clinical trials, ongoing, looking at some of these drugs, as you said. So as you said, there might be something on the horizon, but the carefully controlled studies need to be done before they can be given to given to the patient. So we can, that we are hopeful that some of these drugs might be, helpful, not just for the polyps, but the other PTEN related symptoms as well, and hopefully, help alleviate some of those symptoms.
Yeah.
Okay. Are there any other questions from anybody?
So the one I can see from Olga at the very bottom, is there a cure for anemia in PTEN other than iron supplements? So it depends on what type of anemia. Most commonly, it's going to be related to deficiencies in iron. In ladies, I would be always asking, are you having problems with your periods? Are your periods very heavy? Is there something we can do to help from that perspective? I'd ask about bowel symptoms and be thinking about the celiac, which we've heard a number of times is a very common cause for people to be anemic. And then I'd be looking at polyps and polyp burdens, because sometimes you can ooze little bits of blood continuously from these polyps. Not that you ever notice, but the first thing that you notice then is that you become anemic or you're found to be anemic. and by treating polyps, removing polyps, then that may help. So it's very much a case of having an open mind to think about all the different causes of a low blood count or anemia and addressing each of those and making sure you've ticked all the boxes rather than just assume it's one thing.
Okay. We've got one last question. Suzanne's asking if there's a connection between PTEN and glycosylated acanthosis.
Glycogenic acanthosis, yeah, we see that in the esophagus, so the gullet, food pipe. They're little white plaques. They are really, really kind of, if you see them, then the first thing you think of is PTEN. Okay. So I've never seen them outside of PTEN, but not every patient with PTEN has them. They're a very curious finding, but they don't really mean anything from your perspective other than it can help a diagnosis.
I've never heard of them, so it's definitely not something that's
glycogenic acanthosis.
Yeah,
I'll tell you what, if I can, let me see if I've got it on here. If I can, I'm not sure if I'm able to.
I can make you the host, so that should do the trick.
Okay. I'm used to using Teams, but let me see how I share on this.
I have lost. Where? Just a second. Let me see. Make host. So.
Oh, I'm host. How exciting! Now, share screen. Here we are.
Is this the same as, people who have type 2 diabetes, they tend to develop, is it acanthosis that of the skin?
No, this is very different. So I don't know whether you can see that.
Yeah, we can see it now.
The screen. Let me just magnify that. Oops. So that's a picture of somebody's gullet, and you see those little white blobs? Mm-hmm. That's what we're talking about. That's very typical for patients with PTEN.
Okay.
So that's what we're talking about when we talk about glycogenic acanthosis.
Okay. That's very interesting because it's not something we talk about when we talk about the different, symptoms of PHTS. So.
Yeah, so it's interesting. So there are scoring systems to help you make a diagnosis and to predict whether or not they're doing genetic testing can be helpful. That's probably one of the really good ones, but people don't recommend routine endoscopy. So because you don't routinely have chemo tests from the top, it may well be that people haven't heard of it, but having a larger head and having that are two very characteristic features of PTEN.
Yeah. Okay. I do not think there are any more questions. So I think I'm going to, now take the opportunity to thank Andy. It's been very useful, and I'm sure, our audience today is going to agree that it has been a very useful and very highly informative session. So thank you so much again for taking your time to speak to us. And I hope to meet you at one of the events sometime soon.
Yeah, absolutely.
And thank you.
Thank you.
Nice to see you smiling